Good evening, everyone, and thanks so much for joining us tonight for our Exercises Medicine webinar. This is the first one tonight of 2 sessions. I'm Liz Robinson, Education Coordinator with the Western PHN, and I'd like to welcome our presenter tonight, Shannon Short. Hopefully you've had a chance to read her bio as you've joined in tonight. So Shannon's an exercise physiologist in Bathurst here. We'll start tonight with Welcome to Country. The Western New South Wales Primary Health Network acknowledges that we work on the traditional lands of many Aboriginal clans, tribes and nations. I'd like to pay respect to elders past, present and emerging, and acknowledge the traditional custodians who care for this land on which we work and live. I acknowledge and respect their continuing culture and the contribution they make to life of the communities in our region. The webinars this week and next week are being recorded, and we'll make those available for viewing on our website. After you attend the second of these webinars next week, we'll send you a link to a survey. If you could complete that for us, that would be great. If you haven't used GoToWebinar before, there's a grab panel which has got that little orange arrow up there, up the top. If you click on that orange arrow, it opens up the control panel and you'll be able to see that bigger section there open up. Everyone's automatically in listen-only mode to optimise the sound quality. So if you have a question, just use the questions box, which is down here. And Shannon's happy to take questions as we go tonight. Just click on the triangle to open up the questions box to put your questions in. And I'll hand over to Shannon to start the show.
Thanks for that, Liz. Okay, so all right. Now just let me know if you can see all that without any problems.
Looking good, Shannon.
Okay, perfect. Thanks, Liz. I didn't get you before you went off mute or onto mute. Okay, so thanks for joining, everybody. And from Liz was just letting me know that based on the registrations that we've got a bit of a snapshot across different professions as well within from GP through allied health. So it's great to have a nice little spread across the fields online tonight. So thank you so much for joining us. Tonight is really about focusing on how exercise can be beneficial to improve health measures. And this presentation is put together by Exercises Medicine, and I'll explain who Exercise Medicine is very shortly. But essentially, the focus is that exercise is the best, cheapest, and most accessible medicine available. So Exercises Medicine Australia, they are a global program led and funded in Australia by Exercise and Sports Science Australia, which Exercise and Sports Science Australia is our governing body for exercise physiologists and exercise scientists, as well as sports scientists. Their focus is to empower primary healthcare providers to effectively counsel patients about physical activity leading to sustained behaviour change. It also promotes evidence-based screening to easily identify when and how to refer patients to appropriately trained allied health professionals to deliver exercise treatment services. And within this presentation, there will be a screening tool that I can make available to you. I will get Liz to send that out just to make it really easy so that you can access that screening tool. From these few links here, the main two probably that I really want to highlight is I'm going to show a short clip from this YouTube clip of Dr. Mike Evans just talking about the benefit of exercise and how it works in for improved health measures. It is 9 minutes long, so I'm not going to show the whole video of that purely so that we can keep moving through the presentation. However, the links can be available to you as well. So if you're wanting to watch it further, you'll be able to grab that one. The other that I really will work through is this little snapshot around Australian doctors in their medical curriculum regarding physical activity training. So I'll go through those two quickly. There are the other two predominantly around about the guidelines of physical activity and the recommendation for the amount that someone should be achieving across the week. And we'll touch on this further as we go along. So I won't worry about pulling up those two articles with those. So we'll come into the YouTube link first. I actually have it over here. I'll just jump out of that one and come in here.
obesity and no exercise, that's a very bad combination. And that's where we saw many of the negative consequences of obesity from a health point of view. But if the obese person is active, even if they didn't have the weight loss, but were just active and obese, that was much, much better, and that the exercise ameliorated much of the negative consequences of obesity. So if exercise is a medicine, what's it go?
So if you're wanting to come back into that one and watch that, I'll make sure I send the links through. There's obviously lots more to go into, but we're going to be covering a lot of that here in our slides tonight. Now I can see there's a question flashing up.
Sorry, Shannon, I think we had a
Sorry,
bit of a
Katie.
problem with sound there, so we'll
Yeah,
definitely send the links out for those
yeah, yeah.
videos to everyone.
Yeah, no worries. So that was the only YouTube one that I was going to slow, and I only just saw the flash at the end. So apologies on the volume, everyone. I'm not sure if you get to hear it. So the other one, actually, let me just go back for a sec, because I did say I was going to touch on this one here. So here is an evaluation that they did on the physical activity training provided to medical students, and they basically did a phone interview, and it was done from June to October 2015, and they looked at a few different Australian medical schools who were knowledgeable about their curriculum content. They were invited to participate in the study, number of programs, hours of physical activity training instruction, also institutional attitude towards offering physical activity, barriers experienced, and content areas in which physical activity training was offered were explored. So of their results, 17 of the 19, so 89% Australian medical schools participated in the study. Among the responding schools, 15 reported providing specific physical activity training to medical students. 13 of these 15 schools taught the National Aerobic Guidelines, while only 7 taught the National Strength Training Recommendations. 4, 5, and 6-year programs reported providing an average of 6.6, 5.0, and 12.3 hours of physical activity training, respectively, across their entire curriculum. And only 42.9% of the schools that had physical activity training reported that it was sufficient for their medical students. So nearly half of their respondents reported no barriers to implementing physical activity training into their medical curricula. Of that, research, they reported including some training in their medical curriculum, and key topics such as the strength recommendations, however, were not taught by most schools. So given the importance of physical activity for the prevention and treatment of numerous mental and physical health outcomes, they suggest that it's unlikely that the attention it currently receives really prepares medical students to treat patients with regard to continuing to provide them advice around exercise, which is essentially why we are bringing this presentation to be able to help with tools in providing you in your guidance towards your patients and screening them of those who maybe are being active and those who aren't active, and then who's ready and not ready, and then progressing then forward to on referral for appropriate exercise interventions. So I'll just drop that out of the way there too. So there's lots of different statistics when it comes to exercise and the improvements or reductions that it can do with different chronic diseases. And so just here in front of me, we've got a snapshot of some of them. 60% reduction to reduce the risk of colon cancer, decreases depression as effectively as medications or behavioural therapy. 40% reduction in the risk of heart disease, and a third reduction in the risk of developing Alzheimer's. And that you can obviously Exercise Medicine website as well has lots of different fact sheets and information all on their website. So it's a great tool to be able to hop on and explore. The other component, particularly on anxiety and depression, is that the effects can be felt straight away. As soon as they are being active, they get those improvements from the changes in their mood. So that's a great thing when you can have a dose and then you get a response straight away. So continuing along, almost a 50% reduction in breast cancer for mortality and risk of reoccurrence, almost 50% reduction in incidence of high blood pressure, 20% reduction, lower risk of stroke, and also almost 50% reduction in the incidence of diabetes. And without obviously knowing the number of what the current running stats are for the most diagnosed or most prevalent condition at the moment, I imagine that some of the things that we've just looked here in terms of the statistics for different conditions, that a lot of these conditions are very common. Particularly when we're looking at high blood pressure and diabetes, they're becoming I know for me, with the patients that I have coming through, that a lot of them have a lot of these conditions. So seeing that the impact it can make is a really great one. Now I've just noticed I've got okay, so that was just you, Liz. So I'm just checking in when I see that flash for questions so that I make sure I can keep on top of it. So Liz, jump in at any time if someone has a question so that I can answer it as we go as well.
Will do.
Perfect. Okay, so in terms of inactivity, we're looking at the effect of low cardiorespiratory fitness on mortality, which in that YouTube clip that we had up before, which you'll get the link to watch further, it was discussing this exact table here, that having low cardiorespiratory fitness tended to be the most contributing factor for all-cause death. So here we're looking across a lot of the other different conditions, and like obviously hypertension is seen quite high here for men. However, if we're looking at the total numbers, that the low cardiorespiratory fitness really is a significant impact on that. So touching base back to that video again, he was discussing how even if someone is not necessarily getting the weight loss benefits if they're obese, but they're getting improved cardiorespiratory fitness, then they're really going to make a significant impact on their overall health status. So essentially we're looking at how much, and this is why I didn't really touch into those other couple of articles, because we're going to cover it here. Now, it can seem quite large, or when someone talks in regards to minutes, so particularly if we're looking at 150 to 300 minutes of moderate activity. However, if you increase your intensity to vigorous, it reduces down the time required. So when we chat to clients about how much activity we'll be looking at doing, while we provide them with recommendations, for some people it's building them up to that, because their terms of readiness, they may not be at the point where they can actually see themselves engaging in 150 minutes of exercise a week. In breaking that down for them and saying, okay, so this is 30 minutes, 5 days a week. It doesn't have to be all done in the one block. It can be broken up. So that's important when we are discussing that with the patients, to make sure that we're coming to where they're at, but also showing them that there are ways that they can accumulate that, and it doesn't have to be in big blocks. Aside from the cardiorespiratory fitness, then strength training is also really important. And it should be done at least 2 days a week. And with the strength training, it can be quite varied in terms of the types and the modes, and it doesn't necessarily require resistance training equipment or weights. It can be done even with body weight, and there's lots of different ways of doing that. Another point that we tend to try to get across to our patients is that trying to minimize and not have any more than 2 days of rest from activity. But if you can be active on more days than you don't across the week, for here it's obviously building up to being on most days, or if not all days of the week, being active in some shape or form. So when we're looking at
Question,
intensity,
Shannon.
yeah.
Sorry, we've got a question from Cho. Someone
Yep.
with a BMI of 47 with knee pain, what
Mm-hmm.
exercise would you advise?
So it would be a twofold approach. Some aerobic exercise, you could either use that in the pool. The pool is good because it takes away obviously some of their body weight and makes it easier for them to be able to exercise. The challenge with sometimes when they get into the water is they feel really good, and the first few times they can tend to want to overdo it. So trying to get them just to start small and build up. Cycling, as in a stationary bike or even a foot pedaler, are really great tools as well. Particularly the foot pedalers, you can pick them up quite cost effectively, and I've found that some people are more likely to actually utilize those compared to going out and getting an exercise bike that's, say, a stationary one. The other side of the knee pain is that it's really important to develop strength of the legs to support the knees. Obviously, reducing body weight is going to help to reduce the pain down as well. But if the muscles aren't strong, then they're going to have an increase in knee pain because of the load placed more on the joint. Essentially, it is quite challenging when you're working forwards with knee pain because they're initially going to feel a little uncomfortable when they start to exercise, but supporting them through that and letting them know that it's going to progressively getting easier and just starting at where they're feeling confident to start. So twofold approach, aerobic that can unload the joints, and then strengthening to help support the joint and get them stronger so they can then build up the other activity from there.
That Cho's got, Shannon, is if there is no pool to use, what do you do?
The foot pedalers are a really good one, or alternatively, even if they can only do short walks, that might be, down their driveway and a couple of steps down the block or something and back, and that might be all that they can do at that time, and they build them way up. But really trying to focus on the strength work to enable them to be able to progressively build up their walking tolerance and also their tolerance on the foot pedalers. That definitely, it's a twofold approach so that they have greater ability to be able to withstand the loads they're carrying, and obviously still probably supporting them with referral to a dietitian to assist with strategies around food. The other challenge is depending on their muscle mass. If they're really low in muscle mass, they're not going to be burning off much energy as they're moving, but trying to increase their muscle density will assist them with weight loss long term as well.
Just have another question from Stephanie.
Yep.
She's in a rural and remote area. They don't have access to specialists. Is there any documents or resources on how to recommend exercise as a registered nurse in primary healthcare?
Absolutely. So I'd really would recommend getting onto the Exercises Medicine website and the fact sheets. There's different fact sheets on different conditions, which then will put some recommendations for time or amount of exercise on there. And at the moment as well, being with in terms of access, with obviously because of the COVID situation currently, that there is telehealth available. So maybe trying to jump on to connect with someone via telehealth. Like I'm thinking in terms of an exercise physiologist, I believe there was talk at the extending out the telehealth availability through till next year. I was still waiting for confirmation on that, but that might be something at the moment. I know that's only a short-term solution while the telehealth services are available, but you could connect some of them with someone to be able to have that conversation online, but utilize then the fact sheets from Exercises Medicine, and really advise them that they need to just maybe do less than what they think they can and build up progressively. That way they can feel confident and safe, and then just let them know that at any time if it doesn't feel right, then they should just stop what they're doing until then they're able to discuss with someone further. So coming into the intensity and type, you've probably possibly had a chance to read around that. So talking ability is really a great way for people to gauge how hard they feel that they're working. So moderate being hard enough so you can still talk, but you couldn't sing. So I suggest to people, like, because a lot of people will go walking with friends, and when they tell me that they're walking with a friend, I ask them, are you puffing a little bit, or is your conversation a little bit disjointed? And if they say, oh no, we're able to talk the whole way along, then it gives indication that they're probably not quite walking at a moderate intensity, so you have that capacity to be able to build them up a little bit more. Vigorous means that a conversation cannot be maintained uninterrupted and you're huffing and puffing. So that's when you start obviously to increase the jogging and aerobics and cycling. Aerobic activity, so we're just going through now the different types. So it is any thing that works on improving blood pressure, cholesterol, heart health, mental health, and it's essentially activities that improve or increase the breathing rate and is really beneficial for heart and lung fitness as well. Resistance training or strength training is to promote and maintain musculoskeletal health and physical independence. And a big part here with obviously resistance training as well is bone density, reduced risk of falls, and as well as we've got here into falls prevention down the bottom for balance, stretching and flexibility, but the strength training really helps with falls prevention as well. So it's a combined approach for balance training. So those were different exercises and types. So on, nice little roll in there into osteoporosis. So essentially what we're looking at for exercise here is it's causing then the bones to modify their shape and size so that they're stronger and better protected from injury. In children and in active adults with low bone mass, regular exercise increases bone mass. In healthy, active adults, vigorous exercise helps prevent typical age-related bone loss, and exercise also increases muscle strength and improves balance, which in turn reduces the risk of falling. I actually have, it's probably a nice little case study at the moment. One of my clients, she had treatment for breast cancer. She's about 2.5 years ago now, and her bone mass has reduced quite significantly. She's has osteoporosis, obviously taking medications to assist with that, but she participates, so she's really active now. She was never active before she was diagnosed with breast cancer, but now she exercises pretty much most days of the week, combination of walking. She attends a local gym doing strength training and some aerobic fitness as well. But she also comes into, we have a group class for cancer survivors, and in that we also ensure that we place impact exercises as well as the strength training and some mobility as well. And her most recent bone density scan, she had an improvement in her bone density, and her oncologist said to her that the improvements would not have been from her medications, it would have been from her exercise, and to make sure she kept going with what she was doing because it was clearly really benefiting her. So that was a really nice thing for her to see, that all the work that she is doing on trying to minimize her risk of reoccurrence and trying to prevent that loss of bone density, she actually ended up with an improvement. So great to see how it impacts there for them. So then looking for type 2 diabetes, studies show that exercise can help prevent or delay type 2 diabetes, improve control of blood glucose, decrease proportion of body fat, decrease the risk of heart disease, and also increase heart and lung fitness in people with type 2 diabetes. Within obviously a big area for this, and one of our focus areas when we are looking at body fat, we take in waist measurements particularly on the upper waist, so that we can modify any programs if we need to, but really looking at that reduction of body fat in and around their organs, pancreas, liver, trying to see the changes through there. And if we're able to work on a combination for them of aerobic exercise but strength as well, strength's really important here so we can increase lean muscle mass, because it's the muscles that we really want to help with the control of blood glucose levels. And obviously trying to highlight for anyone who is with their type 2 diabetes, if they're starting exercise and they have the opportunity to just monitor their blood glucose levels, that's really important for them as they're starting an exercise program as well, so that they can ensure that it's safe to exercise. And we actually have a safety sheet for our clients so that they know what they need to watch for and be aware of for when they're exercising as well. But obviously getting them started, even with walking, is an excellent way of assisting your patients, being sure that they've got really good footwear on as well, particularly if they have any peripheral neuropathy and they're, they've got that good supportive footwear and the socks aren't too tight or anything as well. So moving into exercise for depression, the benefits here obviously they lower the risk of depression now and in the future. It's also an effective strategy to manage weight gain, comorbidities and medication side effects. Effective in reducing symptoms of depression for people experiencing other mental disorders. And the aim to meet the Australian Physical Activity Guidelines, ideally exercise participation should be ongoing. However, a minimum program length of 9 weeks is suggested for those with depression. The other thing that I try to highlight for people with depression or mental health is that it really needs to be a daily dose of exercise. We don't really get a carryover into the next day from the dose of exercise. Whereas with type 2 diabetes, they do get a carry across of a day from the benefits of the exercise the day before. So although we want them to be exercising every day, if they were exercising every second day, they would get the benefits in type 2 diabetes. Whereas for mental health, we're really looking at that daily prescription of exercise. And this is where sometimes motivation can be challenging. And so you're working in with their psychologists so that they can help them with the strategies there as well. So really is an important one, but motivation to exercise can be quite challenging. And this, we want the daily dose, but it really can have quite significant changes and improvements for depression.
Shannon, we just got a question from Helen. Is that safety sheet available on the Exercises Medicine website?
For the type 2 diabetics, there is generally, so we did up on specific that we hand out in our clinics. However, there would be some safety recommendations on the type 2 diabetes, definitely. And also on the Diabetes Australia website, they do have safety tips for people exercising with diabetes in around their blood sugar levels and making sure they're not too low before they exercise, and also hydration, making sure they're not too high with their blood sugar levels. So if it's not on, because I'm not sure the last time I looked at the tip from Exercises Medicine of their fact sheet for type 2 diabetes, so I can't remember clearly. However, the Diabetes Australia website definitely has some safety pointers for sure. But if anybody wants something that like from our safety sheet, if anyone is wanting that, we can definitely provide that and hand that out as well. So for exercise and aged care, individuals who maintain high fitness into their 80s plus years have approximately the same rate of mortality as those individuals with high fitness in their 60s to 69 age range. And here, strength and balance exercises are key. And from experience, I really see quite a, and I'm sure a lot of the participants on here would as well, see quite a stark variation in abilities of people as they're getting older. For some that are quite capable and mobilize around really, really well, have no walking aids, can get up and down off the floor without any problems. And then we have the others that really become quite sedentary. They have low muscle tone and low mobility, high falls risks, and require walking aids. And yes, there are times when some of that can't be fully prevented. However, a big part of it is really strength and balance, particularly. The individuals start to lose the leg strength, so the ability to be able to get up off a chair is reduced. They start to need to use arms and swing to stand up. Things like, putting on their underwear and their trousers go from being able to stand up and stand on one leg to doing it to needing to sit down, needing aids, and the fear of falling over because they don't know how to get up off the floor, the fear of getting on the floor because I can't get off the floor, and that really becomes quite a big safety risk. So I really a big believer that helping people to gain the strength and then the confidence to be able to do the movements is of really high importance, and to be able to keep them functioning as best as possible. So the strength obviously is a big part, because as we age, we have some generalized atrophy. This obviously can be slowed and by incorporating strength exercises, and balance normally is an associated decline with that as well. Asking someone if they're able to stand on one foot, or even have their feet in tandem stance, so one foot in front of the other, without needing something to hold on to. These are some of the things that we do in our balance tests, and becomes quite interesting. And sometimes people don't realize how poor their balance is progressing. So to be able to catch that in the early stages, but also reducing down, and with training, people's balance and strength can improve quite significantly. It just needs to be incorporated into ways that they can do it. And generally what I find, particularly for the older adults, is they tend to integrate it a little bit into their day rather than doing it necessarily as a full workout. So while they're waiting for the kettle to boil, they might be doing a balance exercise or doing some calf raises or something. And then when they're doing something else, I'll do that while I'm here. So it's nicely integrated, but it becomes then a routine that they do. So really passionate actually about making sure that people stay strong as they get old, or have more laps around the sun, as I tend to. I've just taken that on as my new little mantra. Rather than getting older, we're just taking more laps around the sun. It sounds a little bit nicer. Okay, so coming on then nicely into falls prevention. So exercise prevents falls in older people by addressing key factors, which are muscular strength, balance, confidence, and walking speed. Walking speed will reduce down as their strength and balance reduces, and then typically as control and balance reduces as well, they'll become more of a body sway, and they'll tend to rock side to side rather than picking up their feet well. Simple tools that we have to assess, particularly things like walking speed, strength, and balance, little tests like a timed up and go test or tug. Has them sitting on a chair, stand up, walk a few meters, turn around to a cone, come back and sit down. So it really gives a good indication of what people's abilities are like. And then once you've identified those, you're able to then start to layer in the exercise for them. And once you start working in around strength and balance, you really see that they start to feel more confident. Naturally will start to walk faster, which then reduces obviously their risk of falls. So here's a really nice case study actually. When we get into the numbers over on the next slide, I think you'll really find this one quite interesting. So Dean is a 52-year-old male who's diagnosed with myotonic muscular dystrophy in 2016. Dean has signs and symptoms of skeletal muscle weakness, both proximal and distal muscles. He has difficulty in performing manual work tasks as a trades assistant, as he is starting to have minor difficulty with activities of daily living. Dean has been previously diagnosed with cardiac arrhythmia, supraventricular tachycardia, and is obese. So hopefully it's big enough for you over here, but Dean's GP identifies that exercise could slow down or possibly reverse the deterioration in muscular function of myotonic muscular dystrophy patients. So he refers him to an accredited exercise physiologist to improve his strength, balance, flexibility, and aerobic capacity. So there's some of his baseline measures after his initial assessment. So they completed a one-leg stance for balance, and then both on right and left sides. His right side was 9.1 and 8.3 for his left, which being under 10 seconds is poor. An ideal, like if someone can stand on their one leg for 30 seconds, they have really good balance. Then the timed up and go, as I was mentioning, the 10.94 seconds, which is below average, and timed from supine, so lying on their back, to standing, which is 8.64 seconds, again below average. When we looked then through muscular strength, they had pelvic core was level 1, so really not getting many engagement at all. Wall squat, 10.6 seconds, again poor. Modified push-ups in 60 seconds was 34, and he identified they had difficulty maintaining exercise posture. It is good for the number that he completed, but his posture obviously wasn't maintained well. And then for a 6-minute walk for aerobic capacity, he completed 450 meters, which is less than the 600 meters, which is into then an average range. So he's listed as poor. His peak exercise heart rate was 95 beats per minute, and his rate of perceived exertion was moderate. And he also he's taking a beta blocker, so that's why he had a low peak heart rate from the walk test. He completed a 12-week intervention and was monitored and reviewed by the AEP, and he had improvements from his initials. So overall, he reported having an improved quality of life and generally feeling more positive. So he actually felt that he could actually walk around in the backyard and pass the football with his son without feeling tired and fatigued. And I think if you look at what he feels here in his quality of life, that speaks really highly, even though we've got great statistics here showing he's got improvements. Having someone actually feel like they can engage with their son in the backyard, I think really is a big part of that. So we obviously want to be able to have those aspects that really motivate and drive someone to go forward, rather than, can I, sit and stand from a chair 8 times in 30 seconds or 12 times. It's more, can I get down on the floor with my grandkids and then get back up and feel confident to do so? And can I do my gardening without having to worry about how I get up off the floor when I'm finished? So looking then at his results here, so the one leg stance, if we look back, so he was at 9 and 8, so he's here now at 20 and a half and 19.3. So it's a big improvement over 12 weeks for single leg stance. Timed up and go, he was over 10 seconds before, so he's at 7.5. He's 6.4 to get up for the supine to stand, was before he was over 8 seconds. His pelvic core improved to level 4. He's holding for 20 seconds for the wall squat rather than, I think it was a 12 before. A small increase in the push-ups here. He did 34 before, so he already had a lot. But now the patient maintains good exercise posture. So he's managed to improve that strength to be able to maintain his position while he's walking. And he's gone up from 450 meters in the 600 to 600 meters in a 6-minute walk test. Peak heart rate actually dropped by 5 beats there as well. He's still at a moderate for RPE, which you would expect that he would be in that moderate zone. When you ideally with the 6-minute walk test, you want someone to walk as briskly as they can without needing to stop and without running for the 6 minutes duration. So you would expect there to be there in the moderate zone. So that's quite a significant improvement over the 12-week intervention there. And obviously we haven't got listed down the frequency of his exercise or anything like that, but I would imagine that he would have been actively exercising at least 3 times a week, if not more, and with that in combination of strength training and balance work. So this is just a graph that helps to differentiate between an accredited exercise physiologist, a physiotherapist, and an accredited exercise scientist. Essentially, so with the exercise physiologist, a minimum of 4 years at university, and we accredit to our governing body ESSA, so Exercise and Sports Science Australia, within the allied health field as well. Rebates can be accessed through Medicare, Department of Veteran Affairs, work cover, private health insurance, and the NDIS, and can work with high-risk patients. We look through obviously screening and health education, behaviour modification strategies, clinical exercise prescription for people with existing chronic and complex medical conditions or injuries. Comparing to a physiotherapist, again, 4 years of university, and also accrediting to APRA. They're in allied health as well. Their rebates also Medicare, DVA, work cover, private health, and I believe NDIS too. I think that one's just a missed out on there, so I believe they're also in there. Working obviously with high risk patients as well, and specialty for acute conditions and injuries, manual therapy. So manual therapy is something obviously we don't do as exercise physiologists, and particularly, so a lot of your acute conditions particularly sit with the physiotherapist. We tend to be more subacute and onwards from there. And the exercise scientists, so they're a minimum of 3 years qualification. So for an exercise physiologist, you gain accreditation as an exercise scientist prior to the exercise physiologists. They don't have any rebates available with them. They also accredit with ESSA and work with low-risk patients. Again, working with screening, health education, behaviour modification, design and deliver exercise programs, particularly for low-risk patients, so people who typically don't have pre-existing medical conditions, or they can complete and deliver programs that under the supervision and delivery of that an exercise physiologist has prescribed. So if it's a client with pathology and the program has been written by the exercise physiologist, they can then supervise and deliver a program written by them. So that gives you a little bit of a difference between the two. I'm assuming that probably most of what you're aware of here is exercise physiologist and physiotherapist. You may or may not, depending on your profession or who you know, have come across exercise scientists as well. So there's a nice little referral sort of idea of who does what, and physiotherapists and exercise physiologists can work really nicely together, particularly around musculoskeletal patients with the progression and assistance with those conditions as well.
Shannon, we've just got, I guess, a comment from Michael Peterson. For myotonic muscular dystrophy as a progressive disease for which there is no cure, then exercise interventions are no doubt beneficial in the management of this disease, but not curative nor reversible.
Mm-hmm. Yes. So I'm not 100% sure on the question from that. So obviously, it's a delay the loss of strength and function, while it's not necessarily going to prevent the delayed, prevent the loss of strength and muscle mass, but it definitely will slow progression and assist with maintenance of function long term. I'm not sure if that answers your question or not. Let me know if it doesn't. So just expanding a little bit on exercise physiologists. So those are all the things that we just mentioned before. So university trained allied health can assist for prevention and management of chronic disease and injury, work with high-risk patients, and recognised by Medicare, DVA, work cover, and private health insurance, NDIS. And then, like, across those forms, there's obviously a few different ways. Like, so Medicare, there's quite a few different referral pathways through those team care arrangements. Those with Aboriginal and Torres Strait Islanders can access a few extras. Type 2 diabetes patients can access group exercise under Medicare as well, so referral for group exercise. So there's a few different avenues within Medicare. The DVA has changed their structure a little bit with their referrals. It's 12 sessions in a treatment cycle, and then after that, an end of treatment report is completed. And if there's further need, then that will be expressed back in the end of treatment report, and further treatment cycles can be then referred on as well. So, and it works through those 12 sessions in a treatment cycle for DVA. And obviously work cover for an exercise physiologist, it was a referral for initial assessment first. And then following the initial assessment, it is then whatever's the exercise physiologist feels is the best for that client at the time will then put forward obviously a report and a recommendation to the insurer as well to what the client needs, which at max they can then request 8 sessions on a allied health recovery request for the patient, and can continue on in those 8 sessions, so them being the maximum that they recommend can request in a plan. With the work cover one, we do have to wait for approval after the initial, so sometimes there can be a little delay following the initial assessment and then the approval of the plan, depending on the return time frame from the insurer. So I know for Maddie and I in at Body FX, we do mention that to our clients when they're coming in under work cover and let them know that we will have to wait to book them in for follow-up ones until we get their approval back from work cover. Other things under work cover can be even a functional assessment if you're wanting to then look at what their actual capacity is for the certificates of capacity. If you're unsure of where their levels are and you want to accurately reflect that, you can refer them for a functional assessment, so that you can have a good idea of what their lifting and pushing capacities are, so that you can have that accurately on there. And then the NDIS, it's obviously changing progressively as well, but there are a couple of areas of their plans that they can access exercise physiology under as well. So it is building in their supports, but still taking a bit of time there to get that out and about.
Shannon, we've just got a question from Narelle.
Yes.
What are your thoughts on Tai Chi and yoga as a regular exercise plan, especially in regard to aging patients?
Yeah, no, they're excellent. So Tai Chi is actually a really good form of balance training, and now I'm trying to think. There's a program that does highly recommend Tai Chi, and I don't know if it's part of the falls prevention, but Tai Chi is definitely a fabulous program for falls prevention, and also that has the element of time to slow down and focus internally. So the mental health component of that is really nice, as well as yoga. So the benefits of yoga that I really like is the combination of strength and mobility that are required in the poses. And there's quite a vast range of yoga styles, but no matter which style that you do, there's normally an element of strength and mobility required in the pose. And also the layer of slowing down, focusing internally, taking some time to breathe and be able to switch off from your day-to-day as well. So I do really like both Tai Chi and yoga as ongoing forms of exercise. Particularly for yoga, I believe that having someone to assist them and coach them through is definitely recommended. And initially, if someone is quite stiff or tight, they could find it quite challenging, and you still can wake up sore from it. So just if someone's going to it for the first time, having them know that while it is a gentle program, when you start to mobilize or work an area that you haven't before, you can still end up with muscle soreness. And muscle soreness is not something to be feared. It's more that you've done something different and your body has said, oh, this is different. This is a stimulus that I'm not aware of. However, they will improve and progress. And I really believe that if someone can try something 3 times, on that 3rd time, their level of soreness is generally much reduced. This is obviously talking in muscle soreness outside of chronic pain and areas as well. So chronic pain is a lot of a different kettle of fish, but in terms of generalized muscle soreness, 3 times doing a new exercise, and they'll find that will reduce down quite a lot. So great question, that one. So I might just thinking at the time, we're just about up to 8 o'clock. So I'll just touch on this one, which is a typical treatment model. Then I almost say typical. It's probably actually really hard to say typical because everyone will have each exercise physiologist will have their model that they like to follow or what they feel works best in with the client, and then we're obviously coming to then what the client is willing to then engage in as well. So it's a 2-avenue street to work through. However, obviously, if you're looking through the 12 weeks, this is looking at better self-management and taking between 2 to 5 consultations over the initial 12 weeks and a multidisciplinary approach, which if we're looking under the Medicare structure with a team care arrangement, that really is coming into that multidisciplinary approach. So initially have an initial consultation assessment, which then under the Medicare structure or general referrals, everybody generally should be referring straight back to the GP and reporting back, and so outlining what was found during the initial assessment and then the strategies going forward, how frequently you're going to be seeing the client, and then when you plan on reporting back. Following up weekly after that for weeks 2 and 3 for the program follow-up, and then at weeks 7 and 8, a program review and progression, and at then weeks 11 and 12, program review and progression with then a report back again. Now, across that time frame, it's obviously the frequency initially is really important to help someone get their technique and consistency on their exercises as well. Because we generally find while you teach the exercise, you get them to verbalize it back to you and show you what they need to do. And we provide our clients with a handout, plus we utilize an exercise program that has options for them to either bring up their exercises online or on a free app, and which has a video of the exercise as well, so they can watch it. And still with these tools, we still sometimes find when they come back within that short follow-up time frame that they still might not be doing the exercises 100% how you initially had showed them. So the early follow-up is really important to be able to assist them with getting the most out of their exercise, and then progressing and then lengthening them out to then allow to show change And then if someone's only got, say, a couple of sessions that they're referred for, and you are seeing them frequently, you might not necessarily get a lot of change in your assessment measures in that time. But it's also the other, I guess, quality of life outcomes you're looking at is the confidence of them to move and exercise. How are they feeling now that they're starting to engage in that? Are they feeling that this is something that they can do long term? And essentially that's what we do want people to do, is to do it long term. You know, if they're coming for knee pain, then their knee pain stops, we don't necessarily want them stopping exercising then because their knee doesn't hurt, because we want to then prevent the reoccurrence of it. So you're really looking at that long-term approach into an exercise lifestyle, something that they can engage in and sustain long-term. So given it's now just hit on 8 o'clock, I will wrap at that point on that slide, and happy to take some extra questions and things now as well. And obviously we'll go through some more information next week as well. And Maddie, who works with me at BodyFX, she'll be taking us through the back half of the slide. She's on here tonight as well. She's having a little listen in, so she'll take us through the back half there. And I will do some follow-up information as well with the links for the earlier slides, and also I will double check the exercises medicine fact sheet around the type 2 diabetes and safety for exercise, and can put that across to Liz, and she can disseminate that out as well, if that is helpful.
We just had a question come through from Anne. What are your thoughts on the, I think it's HIIT workouts, beginner, intermediate, if no screening risk?
Yeah, HIIT workouts. They are very popular exercise types, and there has been use in research around HIIT style workouts, even with people with cardiovascular disease, and they have had improvements. However, my views are that you need to develop an aerobic based fitness and muscular strength prior to really going into a HIIT style workout. While you will typically, you'll burn more energy and during a workout because it's higher intensity. However, there needs to be a level of screening done to ensure that someone is moving into that activity safely, and they're not going to be at risk of injury, which they're depending on the individual. Some people can be at high risk going into those activities, and yeah, I really think that a base level of fitness and strength and control needs to be developed before you start to go into high intensity. So I guess if you look at it in terms of like a pyramid model, you would be looking at developing aerobic fitness and strength as your base levels. And when you look at HIIT training, typically the variables in here is time and intensity, and so normally as the time reduces down for a movement, intensity goes up. So to increase the intensity, we're either adding heavier movements, so that could be things like jumping, or if they're using loads, the weights will go up so it's more intense, or speed. Now, if you adding those variables and the body doesn't have good control, then our risk of injury really increases. So my views are that you need a base level of aerobic fitness and strength prior to then adding the variables of speed and intensity in there.
If anyone else has a question, now's the time. Otherwise, we'll wrap things up and meet back again this time next week.
And if there's any, Liz, if anyone does have any questions and like they get off later and they think, oh, I should have asked that, or I've got some follow-up things, maybe we can get them to, whether that's, I don't know, sent to you or send somewhere so we
Yeah.
can collate the questions so we can make sure we have them answered when we then do the webinar next week.
Sounds fine. If everyone wants to send their questions through to me, I'll make sure they're ready for next week's session. All right, everyone, thank you for coming. Sorry, Shannon.
Perfect. No, I was just going to say, I know that sometimes I get off webinars and go, oh, I should have asked that.
So we'll catch everyone next week. Thank you, Shannon, very much for tonight, and we'll see you all this time next week. Thanks, everyone.
Perfect. Thanks, Liz.